Which is the best one. We do not have head-to-head data comparing the vaccines.
Because these vaccines, not just Astrazeneca, but all the other ones, have different dosing intervals that they were tested.
So for safety's sake, National Advisory Committee on Immunization settled on, let's just make it everyone under 55.
From the Zoomerplex in historic Liberty Village, the Zoomer with Marissa Lennox.
Welcome to the Zoomer. The first coronavirus vaccine was administered in Canada on December 14th. Now, Health Canada has approved 4 vaccines, with others under review, bolstering the initial scarce supplies. On today's show, we answer viewer questions about COVID vaccines and discuss everything you need to know about the options. How were they made so fast? Are they safe? How effective are they against the new coronavirus variants and more? But before we dive in, let's tee up the topic.
The Astrazeneca COVID-19 vaccine hit a roadblock when Canadian provinces halted use in people under 55 after fears it was linked to rare blood clots. Here's what we know. Over 300,000 doses of the vaccine have been administered in Canada, with no cases of blood clotting reported. Meanwhile, original estimates of the disorder among AstraZeneca recipients were 1 per 1 million people. But a higher rate of 1 per 100,000 has been reported by Germany. Still, EU health authorities say the benefits outweigh any potential risks. According to clinical trials, the vaccine is 62% effective in preventing COVID and 100% effective in preventing death and hospitalization. Meanwhile, real-world data is emerging that the efficacy may be even higher.
All right, let's get to our first question from a viewer at home.
My name is Francesca Guida. I am 68 years old. I am from Etobicoke and I am retired. I have a medical background and aesthetics. Well, my question is, can I choose what vaccine I prefer to receive? Thank you so much.
Dr. Gorfinkel, I'll go to you on this because I imagine you get that question a fair bit.
The advice is always the same. Take the first vaccine that becomes available. We really have a race against time, especially given the new variants. All of the vaccines, emphasis on ALL, reduce hospitalization and ICU. All of them practically eliminate death. Now, we can say that for now, but with the new variants of concern, there may be a bit of a question with some of the new ones, especially that B1351. But the B117 variant, which is by far the most common we're seeing, is taken care of by our vaccines. So we're very lucky. And we don't even know which is the best one. We do not have head-to-head data comparing the vaccines. Understand the trials were done in different countries. They were done in different seasons with different amounts of variants of concern present, with different protocols. So we don't even know which is the best one. So the best one is the one you can get.
All right, let's move on to our next question.
My name is Leanne Herbert. I'm 67 years old. I live in Toronto and I'm retired. And my question is, for those people who have taken the AstraZeneca vaccine, what percentage of them had a blood clot after the first shot and what percentage of them after the second shot?
Dr. Gorfinkel or Dr. Hota, who would like to take on this one?
So I will say we don't entirely know. What we do know is that the majority of the cases that have been reported arose or were detected about 4 to 20 days after having received their series. So that's what we understand. When the actual clots began, it's not entirely clear. And we'll probably learn more over time as we observe more and keep monitoring. So that's a timeline where people are at greatest risk of developing symptoms related to the blood clots and should be monitoring for symptoms that could suggest a blood clot, like swelling of the legs, like headache, dizziness, confusion, pains in the abdomen, problems breathing, chest pains, things like that.
Dr. Gorfinkel.
Put that into perspective. Consider the numbers here. So the numbers they range from a high of 1 in 100,000 cases to a low of 1 in a million cases. So what that means is for me as a family doctor, if I see a generous 2,000 patients, I will not know in my lifetime or career a person who has seen a single case. And think about it. For all of the doses, over 300,000 doses given in Canada so far, we have had 0 cases, like none. So the chances are we're talking about something that is of extremely low risk. Now, I'm not saying that it should be ignored. Of course it has to be looked at, especially when you're talking about providing a vaccination to millions of Canadians potentially. But just to try to put that into perspective, we're talking about something of extremely low risk.
Mm-hmm. And we've not seen a single case here in Canada, so there's that. We need to take a short break. There's more when we return.
In that time that you're waiting for your second dose, what is your susceptibility? So in other words, how protected are you after a single dose of whichever vaccine you have while you're waiting for that second dose?
Welcome back. The federal government maintains that by the end of September, every Canadian who wants to be vaccinated against COVID-19 will be. But as variant cases continue to grow, so too do questions surrounding the vaccines, their safety, and the rollout. Today's episode is all about answering your questions about COVID-19 and the future of this pandemic. So let's get right to our next question.
If more cases have been found in women for the Astrazeneca vaccine for blood clots, why have they discontinued the shot for men?
Dr. Gorfinkel.
Because we're not sure. The numbers are so low, it's hard to know what that really represents. She's absolutely right. The majority of the cases, in fact, the vast majority of the cases were in women, but the numbers are really low. And there were some men on that list. So what do we do with that data? NACI, the National Advisory Committee on Immunizations in Canada, the federal body, looked at it and decided, and I think reasonably, that men should be included in that list. Because it may be that women are overrepresented because they're healthcare workers, because they're more likely to get vaccinated, because that was a sampling bias, because we don't have enough cases to be certain about what's really going on. So for safety's sake, National Advisory Committee on Immunization settled on, let's just make it everyone under 55. Now that's not true for every country. In fact, it's crazy what other countries are doing. Some say we're not giving it to anyone less than 65. The UK is saying, and Italy, we're just going to give it to absolutely everybody. So this is not a question of 100% or absolute rules. What we're talking about is how do you interpret the data? And these are the experts that we have.
All right, our next question comes from Dan in Toronto.
Hi, my name is Dan, and I've had the Astrazeneca vaccine. I guess it's when did you get the booster shot is probably the most important question. Is it 2 months, 3 months, 4 months? I heard this morning that some people are actually waiting 6 months. So it'd be nice to have some confirmation or some information about when is the most appropriate time to get the booster shot. That would be my question for sure.
Okay, Dr. Hota, what do you have to say about boosters? What do we know?
Well, so it's an excellent question. And right now, in many parts of Canada, we don't really have a choice. It's what the government is saying is going to be the spacing of the doses. And in Ontario, for example, it's 4 months at the moment. Hopefully that will change because these vaccines, not just AstraZeneca, but all the other ones have different dosing intervals that they were tested as being effective under. So there are really 2 questions that you need to try and answer. First is, in that time that you're waiting for your second dose, what is your susceptibility? So in other words, how protected are you after a single dose of whichever vaccine you have while you're waiting for that second dose? And the importance of that question is kind of affected by, how much transmission is actually happening in your population that you live in at the time that you're receiving your vaccine. And the second question is, by spacing out the doses, higher at a greater interval than what was originally proposed, does that affect your overall effectiveness of the vaccine? And we're learning over time that there may be a difference in how well these vaccines work in different subpopulations. And some of the groups that have come out have been people who are really immune compromised, who've had transplants, for example, or who have cancer, and in particular blood cancers, as well as those who are older. And there's very, very early data, and I'll emphasize it's early data and it needs to be replicated and explored further, that does suggest that, first of all, a single dose, so the first dose, does not protect you as well if you fall into any of those categories. And then in the case of those who have cancer, there's a possibility that delaying your second dose might also reduce the overall effectiveness of the approach. Now, this all said, there's so much more information we need. And in fact, we got some sort of contrary information in the Astrazeneca trial in particular, where they found that people actually overall did better by spacing out the interval to 3 months rather than, a shorter interval. So I think a lot of questions are up in the air as to how this will affect the overall approach. Right now, as we've said earlier, we're in a race to try and outcompete these variants and to try and get transmission under control. I think the emphasis really is on trying to get doses into, at least first doses into, as many people as possible. And I'm hoping that as we get more information, we can revise that recommendation of, what that second dose interval should be.
Okay, thank you for that. Beverly is next.
Hi, my name is Beverly Holtzman, and I am 62 years old. I live in Toronto. I'm currently retired, previously worked for TD Canada Trust for 33 years. And my question is, should I have to wait 4 months for the second dose of the vaccine, or can I get it in much shorter time frame based on the manufacturer's recommendation to make it more effective, especially since I'm immune compromised since I've had a double lung transplant 3 years ago?
Dr. Gorfinkel, Dr. Hota just sort of touched on this, but I'll get you to weigh in here.
Thank you so much. I would suggest this. For those who are at highest risk, they should be pushing and advocating for themselves to get the vaccine sooner. Why? Because if you are over 75, you have that horrible thing called immunosenescence. Your immune system is less capable of responding as well. So those who are in stage 2A, the highest risk group, older, double lung transplant, that's serious previous lung disease, serious previous kidney disease, the immuno-compromised, those with brain disease, neurological dysfunction. These are individuals whom either they or their family doctor should be advocating to get the vaccination sooner. I personally believe 4 months is excessive. That's not acceptable care. It should be 2 months, maybe 3 maximum, but in that population, they are at an at-risk population. And I think the evidence-based would support getting it sooner rather than waiting.
All right, we need to take a short break. When we come back, we'll have more from our experts regarding your questions about COVID-19 and the various vaccines that are available to you. Stay tuned.
4 months in those age groups, and like those over 75 with those chronic conditions, is not acceptable and should be advocated for sooner vaccination.
So have you heard about the Astrazeneca, the pause?
Yeah.
What are your thoughts on how they handled that?
I think they're doing the right thing by checking, being really sure. I mean, it sounds perfectly okay. And I probably, if that's the one that was offered to me, I would probably take it. Mm-hmm. But on the other hand, if it were somebody in my family that got it and then died, I'd say, why didn't you check it?
The risks of not doing it exceed the risks of doing it. So I would just go ahead with it if I was the people that were in line for it.
With this one, I have to admit I was kind of leery about it at first, if I wanted to get it or not, just because it all happened so fast, and I thought I'd wait and see what happens with other people to see if they're okay, but it seems like everyone's getting it. And I mean, we got vaccinated in elementary school and high school when we were kids, and technology wasn't nearly as good, and we're all still alive, so I'm assuming it will be fine.
Welcome back. That was just some of what our viewers had to say in Vancouver regarding the latest developments in the Astrazeneca vaccine. Today, I'm joined by infectious disease specialist Dr. Susy Hota and family physician Dr. Iris Gorfinkel as they answer your questions about COVID-19, the vaccines, and how we move toward a post-pandemic world. So we'll get right to our next question. It comes from Barbara.
Hi, my name's Barbara Andrew. I live in Guelph, Ontario, and I'm 69 years old. I'm a former nurse, and now I officiate at weddings and just do a lot of distant healing work with people. My question is, I have rheumatoid arthritis, and I'm on a biologic called Actemra. Apparently, Actemra is being used to treat COVID in intensive care units under a trial basis. I just received Pfizer vaccine, and I wondered if my immune response is going to be lower to the Pfizer vaccine because I'm on the Actemra. Thank you.
Dr. Hota?
So I think in general, those who are on immune suppressants or have a suppressed immune system for whatever reason, we're not as clear how well the vaccines will work after a single dose. And then in terms of, the timing of when the second dose is going to be necessary. I think we feel convinced the 2 doses are going to be very important. And there's a lot of uncertainty as we're starting to see that some groups of people with immune compromise, like those who have had transplants, those who have cancer, may actually do better if they have a shorter interval. So I think that's more the question rather than being concerned about the type of immune suppressant that you're on and whether or not it would have any activity against your vaccine.
All right, and Barbara actually has another question. Let's roll that.
My sister was just in touch with me today and told me that a colleague of her husband was just diagnosed with COVID after having received the Moderna vaccine a month ago. Can you please comment on that, whether or not that is a common effect or if it's related to the variants, or do you have any other ideas? Thanks so much.
Dr. Gorfinkel, that's everyone's nightmare. What do you have to say?
Absolutely. And you know what it is? I just mentioned how we're dealing with a summation of imperfectly moving parts. No one said the vaccines are 100%. On a population basis, though, they eliminate the possibility of death. They greatly reduce, not eliminate, the likelihood of hospitalization. So these are population things. Does that mean every single individual who gets it will not die? Well, for now, we could actually say that. It is a vaccine-preventable disease for the most part. But what about hospitalization? Greatly reduced, not zero. What about mild to moderate disease? That's where we're seeing some differences between different vaccinations and the mild to moderate disease. So she doesn't really go into that aspect of it, but yes, there are differences. But his likelihood of winding up in hospital and dying is greatly, greatly reduced as a result of any one of the 4 vaccines.
All right, moving on to our next question. It comes from Daniel.
My name is Daniel Sternfels. I am 66 years old. I am a hospitality manager, semi-retired, and live in Toronto. Studies in Italy published last week sound the alarm that older people and obese people produce significantly lower COVID antibodies after being vaccinated as compared to younger and non-obese people, and suggest this could allow new and more lethal variants to emerge. Based on these findings, do you think the federal government should provide a 3-week vaccination window for older, obese, and immunocompromised people?
Now, I know you're both passionate about this one, but we'll start with Dr. Hota.
Yes, and as more information emerges in different subgroups of individuals, like those who are immune compromised, like those who are older in age, and other health conditions that might also impact on the effectiveness of the vaccine strategy. I really sincerely hope that we revise our recommendations for the dosing interval. And that information is just starting to come out. These are small studies, but I think that there's enough that's been compelling to make many of us question whether having a standard regimen of dosing for all individuals makes any sense.
Dr. Gorfinkel, did you want to add anything?
Absolutely. Don't be shy. Advocate. Talk to your family doctor and find out exactly the risk group. So when we're talking about obese, it's not like overweight is the same as obese, is the same as morbidly obese. So in Ontario, we've decided those with BMIs greater than 40. You know what a BMI greater than 40 is? That would be my weighing about, 250 pounds, something like that. So this is talking about extreme obesity. So we have to parse it out. And the best conversation is have a conversation with your family doctor, understand your true risk. If you're really older, if you have severe kidney disease, this double lung transplant, severe underlying lung disease, heart disease, like we have to understand which category you fall into to decide, should we advocate for a sooner vaccination? 4 months in those age groups, and like those over 75 with those chronic conditions, is not acceptable and should be advocated for a sooner vaccination.
All right, we need to take a short break. There's more when we return.
And so when we're talking about travel, not only are we thinking about that, the fact that we need to have, enough people here in Canada protected, but we're also talking about what's happening in other countries or wherever it is that you're traveling.
Welcome back. Today, our experts are here to answer your questions about COVID-19 vaccines, so let's get right to it. Our next question comes from Alex.
My name's Alex Andre. I'm a director of sales, and if I could get a vaccine, it would be a one-shot deal. So people in their mid to low 40s, when can we get vaccinated, period? And how many, variations do we have to get? Is it going to go on a year from now where we have to get round 2? Those are some of the long-term questions for people in my age group.
Dr. Hota?
It's a great question because when you look at where cases are arising right now, we're seeing a large number of cases in the hotspots that are coming from people in younger age groups. And these are people who are having to work for essential reasons. And, I think that we're going to have to start changing our approach to get out to those who are at highest risk, who include younger people earlier than what the original plan was. So right now, it kind of looks as though the earliest somebody in their 40s will get a vaccine unless they have one of these high-risk health conditions that's included in phase 1 will be sometime in the summer, maybe even later in the summer. I think that needs to change if we really want to get a handle on what's going on. And to the points that have been spoken of already, I agree we're a little bit late in instituting public health measures to try and curb transmission in many parts of Canada where the curve's taken off. But when we do decide to impose things like stay-at-home orders and lockdowns, really it should be with an end at sight, which is we're going to ramp up vaccination in the highest risk groups so that we can actually get out of the lockdown or the stay-at-home order with some hopes of having things under control.
All right, we have another question from Alex.
The question is, when can people start to travel again safely? When can we get on a plane and go to Florida and feel like we can come back without having to, go into a long lockdown or anything like that? And is it safe to get on a plane?
Now, neither of you work for government, but Dr. Gorfinkel, if you could take a stab at this one.
I just wish the news were better. And I have to hang my head because I'm not going to bring good news on this. The problem again becomes the problem of the variants of concern. So we can vaccinate against B117, probably. We can vaccinate against the original variant. But the question is, can we vaccinate against the variants of concern that are in Florida? And, consider this. New York is facing a variant. No one even talks about that variant. And we're hardly even looking for it, called the B1526 variant. So this was identified just a couple of months ago in New York and now accounts for 1/4 of the cases in New York City. So think about it. When you get on that plane to Florida, who do you think is going to be on it? Well, what do you know? The guy from New York. And what do you know? You're going to bring it back to Canada. And what do you know? Canada now has a new variant of concern that we've got to contend with. That's the issue around travel. People don't mean to do it. They feel fine. They feel fine 40% of the time. But guess what? They're still carrying that variant when they come back. Even if you lock them down for 2 weeks, we don't know if that 2 weeks number is true for the B1526 identified in New York. That's the problem. Uncertainty with how effective our vaccines will be, and being humbled by the fact that these variants of concern have spread like wildfire in entire jurisdictions in very short times. Problem.
But once we're all vaccinated and we reach herd immunity, can't we get there?
Well, herd immunity to what? Which variant? That's the question, right? So which variant are you talking about? Herd immunity, by the way, is a very questionable thing. Like you talk about the original variant, we were talking about a herd immunity of 70%. Herd immunity is where it's no longer spreading in the community because enough people have protection. So that's the thing. If you're talking about the new variant, the B117, you're talking about a herd immunity of 90% of Canadians being protected. And then we have this whole question about how effective is the vaccine? So how effective is it against the B1351 variant first identified in Brazil? Like that's a whole question. We don't even know. So what's going to be the herd immunity to that? Well, we don't even know how effective our vaccines are. So it's a bit of an issue. And the number of variants, by the way, every single case represents a potentially new variant that can arise. Every single new case. Because the variants arise when mistakes happen in viral replication. And that's just the nature of the beast. We'll never change that. Sure, most of those mistakes aren't going to amount to much, but the occasional one does. And then a new variant is born.
Dr. Hota, you had something to add?
You know, I think the way that I'm looking at this is our goal is to try and protect people from the severest impacts of this infection. And really, until we get vaccine offered and people have the ability to protect themselves, like on a very broad basis, we can't really lift big restrictions that are designed to try and help the population. And so when we're talking about travel, not only are we thinking about that, the fact that we need to have, you know, enough people here in Canada protected so that if they're exposed, at least they wouldn't be harmed as much from the infection. But we're also talking about what's happening in other countries or wherever it is that you're traveling. So it gets so much more complicated. It's not even like we can set a policy without understanding what vaccine rollout's going to be in all these different countries where people may want to travel. And then, as mentioned, you know, what's the issue around variants in these other parts of the world. So, you know, I think we're far away from having a policy change on travel.
All right, well, that's not good news indeed. All right, we'll get to more of your questions with our experts after the break.
The initial layout of the vaccines made so much sense. It basically asked two questions: who is dying from the disease and who is spreading the disease?
Welcome back. As we continue to navigate this ever-changing pandemic, many have more questions now than ever before when it comes to how they connect with their loved ones in the future. Here's a question from Nancy on that very issue.
Hi, my name's Nancy Bangsvold. I'm 69 years old. I live in London, Ontario, and I'm a semi-retired interior designer. I'm concerned about the push to take a COVID vaccine. While I'm still told that I can't hug or kiss my granddaughter, I still have to wear a mask. I still have to stay in virtual lockdown. And I'm not being offered any guarantee or compensation should I experience serious negative effects from a vaccine. How does that make any sense?
Dr. Hota.
First of all, I want to say that these vaccines are safe. Overall, they're very safe vaccines. So, you know, to the last point that was made, you know, I want people to understand we've got lots of experience with them. But, you know, in terms of lifting restrictions, you will be able to hug your grandchildren. You will be able to do the things that you want to be able to do. It's just a matter of making sure that others who are vulnerable are also able to get vaccinated first. So if we hang tight, The goal is to actually be able to do these things, and it shouldn't be a reason to hold back on getting vaccinated right now.
Because it was just announced that Ontario is now implementing another stay-at-home order. Dr. Gorfinkel, is this the right step forward?
It's really hard. In retrospect, it always feels like we're one step behind the 8 ball. We see the numbers going up, and then we react. The problem is that the countries that have been most successful are not doing it that way. They see small signals and react with decisiveness and much more quickly. Can we be doing things better? I believe we can. But that would require a lot of will on the part of the population. We see signals now in the variants of concern that are hugely concerning because these are not just more contagious, they're deadlier. Young people are winding up in emergency rooms and hospitals and ICU beds. Should this be ignored? No. And provinces are saying, okay, fine, we're going to shut the kids, we're going to shut the schools down. Schools are the last thing that should be shut down. We see malls filled with people. That's really concerning. We see lineups for retail that's not necessary. So I think we could be doing things way better with more decisiveness and earlier on, before the variants of concern are becoming such high numbers. But we're already seeing a deadlier disease, and that's the rationale for lockdowns. But they're probably coming a little late, but at least we're doing them.
All right, that next question comes from Nora.
Hi, my name is Nora. Why weren't teachers vaccinated earlier on, or like the first to be vaccinated?
Dr. Gorfinkel.
The initial layout of the vaccines made so much sense. It basically asked 2 questions. Who is dying from the disease and who is spreading the disease? So that's basically who got vaccinated. We knew that 80% plus of the deaths were in long-term care. So those are the people who got the shots first, the ones who were dying the most, and also the ones who are spreading the disease the most, the frontline healthcare workers, the really front-facing work, and in indigenous communities, and communities where they had no access to good medications. Heck, a lot of indigenous communities don't even have clean water, never mind. So that's why we did the prioritization we did. And even now, the stage 2, it's making a lot of sense. We have a limited vaccine supply, and it has to go to those who are most likely to die and most likely to get sick. So we're trying to target communities that are hotspots, trying to target those people, as I mentioned, with underlying severe kidney disease, brain disease, lung disease, blood cancers. These are the ones who are most likely to get sick and die of the disease. Now, is that a changing script? Of course it is. But that's what science will do. It'll act with agility in the face of new knowledge.
All right, the next question comes from Gordon.
I know that the newer strains seem to be having a different and larger impact on younger people relative to the initial strain. So I'm wondering why exactly that is, and whether or not our hospitals have the capacity to deal with an influx of people coming in from the younger demographic.
Dr. Hota.
There are 2 issues here. So one of them is just around who's actually getting infected. So who's at highest risk of actually showing the signs and then getting sick and they're, so forth. But also proportionally, these variants of concern, we now know, increased risk of hospitalization by over 60%, increased risk of ICU admissions, so intensive care unit admission, by over 100%, and increased risk of death compared to other variants that were earlier by over 50%. So they are definitely causing greater impact. So we're seeing these 2 things converge, and what it's appearing as in the hospitals is we're seeing younger people in our intensive care units than what we saw in previous waves, including just a few months ago. So, the hospitals are working really hard to be prepared to deal with the numbers that we have coming in, but it will require more, in terms of public health restrictions to get things under control in order to cope with the situation.
Okay, and the next question comes from Paul.
Hi, I'm Paul. I'm 50 years old. I'm from Oshawa, Ontario, and I work in media and education. My question is, why are we giving more attention to those people who have legitimate concerns and questions about vaccine safety as opposed to those who are just pro-vaccine? The conversation seems a little one-sided.
Much of the vaccine hesitancy has come from this idea that we developed these vaccines too quickly compared to the way other vaccines are developed, and they go through the approval process and so on and so forth. Dr. Hota, can you speak to that? The speed with which these vaccines came about and therefore their safety?
I actually see this as a win. It's shown us just what can be accomplished if there's really the will behind it. No corners were really cut in any of these vaccine trials. I've looked at the protocols, I've looked at the results of the studies. They're run like any other clinical trial that you would expect to see. So I'm not concerned with that. It's really just there was a push and a drive to get this done. The first two vaccines that were approved actually use technology that is much more rapid in actually developing a vaccine. That's actually what takes a lot of time with much of our vaccine development. These mRNA vaccines can be created very quickly. And then the trials were actually able to be completed quickly because there were so many people who were actually infected and getting infected, and so much transmission of COVID-19 in the areas where they were tested. So, you know, they were done quickly, but it's a triumph of science and will.
What made the trials so quickly is the fact that they manufactured them in advance. Countries purchased them in advance. Billions of dollars was poured into the research. You're not hearing about the thousands of vaccines that failed. And there were thousands of vaccines that never made it to what you're seeing. But what also sped it up was laying down those supply chains in advance. There was a tremendous amount of work done in advance that determined the acceleration of the process. The science was identical. In fact, those research trials are still ongoing, looking for signals. The Pfizer trial, the original trial, that's still ongoing. And same with the Moderna trial. All these trials are ongoing. They were approved in advance because of rolling reviews done by Health Canada and the FDA with emergency use authorization. They granted, we don't have all the information. We have enough of the information to give this approval because of the harms that the disease is now causing. That's what sped up the process. So the science remained the same pre and post pandemic. Nothing has changed in the science. The science is what it is. But there are so many other factors that didn't have to do with the science, that sped up the process, that made it possible for us to have vaccinations in hand that are highly effective in record-breaking time.
Very good points. All right, when we come back, more questions and final thoughts from our experts. Welcome back. With only a few minutes left, we want to squeeze in a couple more questions. But let me just ask Dr. Gorfinkel, what do we know about children, when they will be vaccinated, if they will be vaccinated, and how important it is that kids get vaccinated? Because in the community, it doesn't seem like kids are really being affected by COVID.
Stats Canada tells us that children under the age of 19, if you want to call them children, represent 20% of the population. So achieving herd immunity without vaccinating this group will be impossible. So they are critical. Good news from Pfizer, they looked at 2,200 plus kids between the ages 12 and 15 and found a 100% reduction in COVID-19. So that gives me great hope that we will see a vaccine approved by Health Canada from Pfizer by fall. That's the outlook on that. So I'm excited. We cannot assume that COVID-19 will not infect kids. We know that there are some very weak signals now, but with the new variants of concern coming up, that could rapidly change, as we have seen it change already in affecting young adults. So this is again, one of these moving parts. It could easily change. We cannot assume that kids will remain unaffected by the disease.
All right, the next question comes from Leah.
A question I have is regarding the rollout of the vaccines and what the recommended protocol would be for vaccinating the caregivers who are particularly in my age group of those who are 60, 65, 75, 80. The caregivers are around my age group. We aren't being vaccinated, but that population is. I guess my question is, what would be the recommended rollout to ensure that the caregivers for this population are being vaccinated as well?
Dr. Hota.
You know, outside of those who are residing in long-term care, caregivers of those who are older and in the age groups that we've rolled out to have not really been included, it's true. What will be included is caregivers of those with the chronic or the highest risk health conditions. When that's rolled out, my understanding is that we will start getting some caregivers immunized as well. I think the bottom line here is we just need to get to everyone as quickly as possible, because the more you try to cut and parse things out, the more you find that there are variations that are important. You know, different types of individuals or, you know, different groups of people who really need to be vaccinated because, you know, they're important to get out to. So bottom line, let's just get vaccine out to as many people as possible, you know, as quickly as we can.
All right, and we've got an email question from John in Kingston, Ontario. He writes, how long will it take before we can stop wearing masks? Dr. Gorfinkel.
No, you know, no one's even asking how long it's going to take to wear. You're going to be wearing that mask as far as the eye can see, at least for another year. That's my guess. We need to have vaccines that are highly effective against all emerging variants of concern, and it's not clear at all when that will be. So for now, don't throw out your mask, keep shopping, keep reading the latest on what constitutes the best mask. We know the best mask is made of multiple layers, fits closely to the skin. And in fact, there's even questions now about should we be wearing them outdoors? And the answer is yes, especially if it's in a high congregate setting. Now, if you're taking a walk, a hike by yourself alone in a big field, well, of course, you don't need that mask in that situation. But if you're going to a barbecue with 10 other people or something, you better wear that mask, and ideally even a face shield. It's sad to say that, but that's as far as the eye can see right now.
All right, we've got a few seconds left. So panelists, will you leave us with some of your final thoughts, Dr. Hota?
First of all, I'll say, you know, we're at an exciting point that we have great supplies of vaccine. And so it really is up to all of us to do our parts. This is something that we can take control of to try and end this pandemic and get back to a more normal looking life. So let's take advantage of that. That's my message to people. You know, things might change in recommendations, listen to what's coming out, absolutely. But please do your part. This is something we can all do to end this pandemic.
And Dr. Gorfinkel.
Don't be afraid to advocate. Don't be afraid to step up to the plate and ask, am I in one of those higher risk groups that needs that second vaccine sooner? We're getting millions of doses of vaccine. Talk about moving parts. So even if for somebody who's been given, say they're in the highest risk category and yet they've been given an appointment for dose 2 4 months apart, here's a little practical tidbit. Go to your family doctor. Get your family doctor to write a letter. You yourself can advocate. No, I'm in a higher risk group. For that woman who asked the question, she's an essential caregiver, guess what? She gets the vaccine because she could be spreading it not just to one person, but to multiple people. Advocate for yourself. Get your doctor to advocate for you. Ask yourself and your doctor, am I in that high risk category that needs that kind of advocacy? Because it's there, the vaccines are there. Reach out, try to get them, and don't just lie down.
That's all the time we have. Thank you to my panelists for being here and for you at home watching. We'll see you soon. For now, it's time to zoom out.